Borderline personality disorder, BPD, is a constant condition, not merely episodic. It isn't a switch flipped on and off. It's a relentless undercurrent of emotional chaos and anxiety that can surge without warning. Understanding BPD means seeing the storm, not just the lightning strikes. Unlike mood disorders such as bipolar disorder with clear highs and lows, BPD is a pervasive condition. Chronic instability in emotions, relationships, and self-image forms its core. Think of it as a storm always brewing beneath the surface, and triggers setting off the hurricanes, thunder, and lightning strikes. Triggers include stressors like perceived rejection or criticism, which increase to a critical level, already severe baseline turmoil, which in turn sets off intense outbursts of rage, panic, or despair. These episodes can be confusing for both the individual and observers, as the intensity of the reaction may feel out of sync with the initial trigger. Individuals with BPD often possess, on some level, an underlying awareness that their responses are extreme, but feel powerless to control them, and this self-awareness leads to feelings of profound guilt or shame once the episode subsides, contributing to a cycle of emotional distress. Outsiders may see manipulation, but internally, it's a battle against overwhelming fear and pain. A late partner isn't just late, it's proof of impending abandonment, triggering survival mode responses. Therapy like DBT teaches emotional navigation skills, while compassion from others helps rebuild trust. Follow me for more insights into BPD's causes, symptoms, and treatments.
For those with borderline personality disorder, abandonment isn't just emotional heartache. It can feel akin to searing physical pain. Neuroscience reveals the brain equates rejection with bodily harm, turning perceived signals of such rejection by people with BPD into searing pain through shared neural pathways. Intensified by BPD's emotional turbulence, this mind-body overlap fuels desperation and self-protective acts. To those with BPD, abandonment feels like physical injury. So what's happening in the brain when someone with BPD experiences rejection? Well, first, it's important to understand that a brain region called the anterior cingulate cortex, or ACC, is activated during both physical pain and social rejection. The dorsal ACC, in particular, is associated with distress from social exclusion. Secondly, another brain region called the amygdala is hyperactive in BPD, amplifying threat detection and emotional responses to perceived abandonment. Brain scans show that social rejection lights up brain areas like the dorsal ACC and insula, which are also involved in physical pain processing. In BPD, this activation may be more pronounced. Additionally, those with BPD are hypervigilant to perceived signs of rejection and abandonment, often interpreting them as catastrophic threats. They have great difficulty controlling emotional reactions to such signals, leading to overwhelming fear, anger, or despair. This may stem from childhood trauma or unstable attachment patterns. Social bonds are critical for survival, so the brain may treat rejection as a physical threat to motivate connection seeking. Indeed, social pain and physical pain both engage endogenous opioids. However, dysregulation in this system might exacerbate emotional pain in BPD, prompting maladaptive coping, like self-harm, to trigger pain relief pathways. In simpler terms, both emotional pain, such as feeling sad or lonely, and physical pain, like a headache, can activate natural pain relief chemicals in our body called opioids. However, if this natural system is not working correctly, it can make emotional pain worse for people with borderline personality disorder. As a result, they might resort to unhealthy ways to cope, such as hurting themselves, to try to feel better by activating those pain relief pathways. What behavioral responses can these unusual brain activities give rise to? To avoid abandonment, individuals may exhibit clinginess, aggression, or preemptive rejection of others. These automatic responses are largely unconsciously driven to reduce perceived threats, but often strain relationships to their limits and are thus often completely self-defeating. But therapy offers hope. Dialectical behavior. Therapy, developed by Marsha Linehan, a world expert in BPD who suffered from the condition herself, teaches emotion regulation, distress tolerance, and interpersonal effectiveness. Social support is also crucial, as is validating the emotional experiences of the person with BPD.
Psychotic episodes in BPD, if they occur, are typically short-lived, only spanning from moments to hours or at the most a few days, and closely linked to emotional triggers like intense stress, fear, or distress, creating a storm that one can often recover from quite quickly once the emotional turmoil subsides. In contrast, primary psychosis in conditions like schizophrenia manifests as a persistent disconnection from reality, with symptoms that linger for weeks or months or years, even in the absence of emotional upheaval. For someone with BPD undergoing a psychotic episode, sometimes called a pseudo-psychotic episode, there exists a layer of awareness, an understanding that the fears and voices echoing in their minds are fabrications of a turbulent emotional state. This contrasts sharply with the unwavering convictions held by individuals with schizophrenia, whose beliefs in hallucinations and delusions entrench them deeper in an altered reality. The very essence of the experiences also drastically varies. BPD psychosis tends to reflect personal insecurities and emotional struggles, shaping voices and perceptions that amplify feelings of worthlessness and shame, while schizophrenia tends to present extravagant, detached hallucinations that are clearly, completely illogical. Delusions in schizophrenia are often termed bizarre by psychiatrists, meaning they couldn't conceivably be true, such as "my brain's controlled by the government by remote control." But in BPD, they are typically non-bizarre and more akin to distorted and exaggerated thinking, such as "everyone will always hate me and I'm going to be severely punished," or "I'm the world's most unlovable person and will be publicly exposed as such." Treatment avenues also differ notably, where BPD-focused therapies emphasize emotional regulation and trauma processing, while schizophrenia typically necessitates ongoing medical intervention and support. Understanding these nuances is crucial for effective treatment and compassion for individuals navigating these complex conditions.
An often overlooked aspect of BPD is its profound impact on sleep. Research has shown that individuals with BPD frequently experience disturbances in sleep continuity, such as increased sleep fragmentation and decreased sleep efficiency. A study published in JAMA Psychiatry found that adults with BPD exhibited significant sleep disturbances compared to those without the disorder. Participants reported difficulties in maintaining uninterrupted sleep, often waking multiple times throughout the night. This fragmentation can lead to a feeling of unrest and grogginess during the day, exacerbating emotional dysregulation and impulsivity, which are hallmark symptoms of BPD. Moreover, research suggests that BPD may specifically alter the regulation of rapid eye movement, or REM sleep. REM sleep is the sleep stage where dreaming occurs, and it plays a crucial role in emotional processing. A study published in Sleep Medicine Reviews highlighted that individuals with BPD often experience increased periods of REM sleep, which can lead to vivid dreams and nightmares. These disturbing dreams can result in further sleep avoidance and anxiety about going to bed, creating a vicious cycle of sleep deprivation and emotional instability. The alteration in REM sleep regulation contributes significantly to the prevalence of nightmares among those with BPD. A study in personality disorders theory, research, and treatment noted that many individuals with BPD have reported recurrent nightmares, which can heighten anxiety and fear around sleep itself. This fear can lead to difficulty falling asleep, resulting in a cascade of emotional and psychological distress. Given the significant impact of these sleep disturbances on individuals with BPD, addressing sleep hygiene and seeking professional support is crucial. Cognitive behavioral therapy tailored for insomnia, or CBTI, may be beneficial. And integrating talk therapy to address the emotional aspects of BPD can also create a more holistic approach to treatment. If you or someone you know is struggling with these issues, reaching out for support is essential. Raising awareness about the profound connections between BPD and sleep can help foster understanding, empathy, and ultimately, recovery. Share your experiences or tips on managing sleep with BPD in the comments. Follow me for more insights into BPD causes, symptoms, and treatments.
Understanding the hidden influences on how our minds work when we have borderline personality disorder, BPD, is crucial to gaining insight into our difficulties and, ultimately, overcoming them. One key to this complex journey lies in recognizing early maladaptive schemas, EMSs, which are patterns formed in childhood that shape how we perceive and interact with the world around us. Early maladaptive schemas are harmful thought and emotional patterns that emerge during our early years, particularly when our emotional needs aren't met. These deep-seated beliefs continue to affect us throughout life, influencing how we see ourselves and our relationships. EMSs are tough to change and persist across situations and often lead to unhealthy coping methods like avoidance and substance abuse. Here are 5 common EMS in BPD and their childhood roots. 1. The abandonment instability schema. For example, a child who experiences inconsistent caregiving. Perhaps a parent who is emotionally unavailable or unpredictably volatile may develop a belief that relationships are unreliable. This instability can lead them to fear abandonment in their adult relationships, prompting frantic efforts to keep loved ones close to avoid perceived rejection. 2. The mistrust abuse schema. For example, a child who suffers from emotional or physical abuse may grow up expecting others to hurt or betray them. If caregivers display manipulative or threatening behavior, the child learns to anticipate harm, leading to paranoia and a reluctance to trust others as adults. 3. The emotional deprivation schema. For example, when a child's emotional needs, such as affection and support, are consistently unmet, perhaps due to neglect or dismissive parenting, the child may internalize the belief that their needs will never be fulfilled. This can result in chronic feelings of emptiness and a lifelong search for validation from others. 4. The defectiveness shame schema. For example, a child who is constantly criticized or compared unfavorably to siblings may develop a sense of fundamental shame and defectiveness. This pervasive belief of being flawed may translate into self-hatred and self-sabotaging behaviors in adulthood. 5. The social isolation alienation schema. For example, children who feel different from their peers, perhaps due to bullying or family issues, can grow up believing they are fundamentally excluded from social connections. This sense of alienation contributes to difficulties in forming stable friendships and can lead to further feelings of insecurity in adulthood. Recognizing the connections between BPD and early maladaptive schemas can be the first step toward understanding ourselves better. By identifying these deep-rooted beliefs, we can work on healing and developing healthier patterns of thought and behavior. Treatment options focusing on these schemas, such as schema therapy, can help pave the way to improved emotional well-being and stronger relationships. Follow me for more insights into BPD's causes, symptoms, and treatments. Ever felt like screaming out in utter desperation, "Why does nobody believe me?" In this very short video, let's look at how bias hurts people with borderline personality disorder according to a very recent study. The 2024 study by Watts and published in BJ Psych International reveals a troubling pattern. People with borderline personality disorder often face disbelief and dismissal from the very professionals meant to help them. The research highlights how stereotypes like viewing BPD patients as manipulative or overly dramatic lead to unfair treatment and poorer mental health care. Here are 2 key findings from the study. 1. Testimonial injustice, when patients aren't believed. Clinicians often discount what BPD patients say, assuming they're exaggerating or seeking attention. For example, a patient describing severe emotional distress might be labeled as just being dramatic instead of receiving proper care. 2. Hermeneutical injustice, when the system fails to understand. Medical frameworks sometimes lack the language to fully capture BPD experiences, leaving patients struggling to explain their symptoms. Without clear terms to describe their pain, many feel misunderstood or even blamed for their condition. These 2 injustices have several knock-on detrimental effects, including misdiagnosis, the undermining of trust in therapeutic relationships, and an increase of the stigma surrounding BPD. Watts's research suggests improvements including training clinicians to recognize biases against BPD, using trauma-informed care that focuses on patient experiences rather than stereotypes, and listening without judgment so patients feel heard and supported. Mental health care should empower, not undermine, people with BPD. Follow me for more insights into BPD.
What is the impact of borderline personality disorder on everyday living? Borderline personality disorder doesn't just affect emotions. It can disrupt work, relationships, and daily life even more than major depression or chronic illness, leaving many struggling with severe disability. Thadani and colleagues found that individuals with borderline personality disorder scored a mean of 50 out of 100 on the World Health Organization Disability Assessment Schedule, which is at the threshold of severe disability. This score is notably higher than that seen in major depressive disorder, where Chang and colleagues report a mean score of 37.7, and also higher than in rheumatoid arthritis, where Meesters and colleagues found a baseline score of 40.5. The impairment in daily functioning for borderline personality disorder patients is not only greater than major depressive disorder and rheumatoid arthritis, but also comparable to or worse than chronic physical illnesses such as diabetes, asthma, coronary heart disease, chronic pain, and Parkinson's disease, as noted by Lawrenson and colleagues. Perceived social support is significantly lower in borderline personality disorder, and its reduction further exacerbates functional impairment. Enhancing social support is suggested as a therapeutic target to help preserve or improve functionality. Follow me for more insights into borderline personality disorder. Understanding brain differences in people with BPD can be a relief. It means your struggles are not your fault. They are not signs of being broken or bad. They are signs that your brain has adapted to survive tough times. Two small but extremely powerful regions of the brain, the hippocampus and the amygdala, play a major role in how we process emotions and stress. Research has shown that people with BPD often have smaller hippocampi and amygdalae compared to those without the disorder. Studies find that the hippocampus can be 11 to 20% smaller and the amygdala 8 to 24% smaller in people with BPD. What does this mean for you? Firstly, it means that the emotional intensity of those with BPD is not a character flaw. The amygdala is like your brain's emotional alarm system. If it's more sensitive due to past trauma, it can make feelings hit with overpowering intensity. So emotional reactions in people with BPD don't reflect weakness or lack of willpower. They occur because of how your brain has been wired, often by early life stress related to severe and protracted trauma. Secondly, it means difficulty handling stress is also not our fault. The hippocampus helps manage stress, but when it's smaller, as it often is in those with BPD, stresses that people without BPD may be able to cope with more effectively can be completely overwhelming. Again, this is a biological response, not a personal failure. It is also vital to note that volume loss in these brain regions is more acute the more intense and protracted the person with BPD's experiences of early life trauma and stress have been. This shows just how powerful and lasting the effects of traumatic experiences can be. Your feelings make sense in the context of your brain and your story. Your brain became biologically adapted to the environment in which it was shaped. Your brain is not your enemy, it's a survivor, just like you, and you can heal. Thanks to its neuroplasticity and therapies like dialectical behavior therapy that capitalize on this, the brain can change and so can your life. Follow me for more insights into BPD.
Imagine walking into a room and feeling certain that every whisper, every glance, and every laugh is somehow about you. Roughly 1 in 4 individuals with BPD are affected by ideas of reference, where they interpret neutral events as having personal significance, according to a 2021 study published in Comprehensive Psychiatry. Here are 10 examples of ideas of reference that research has shown individuals with BPD may experience in a variety of everyday situations. Research by Zanarini and colleagues in 2013 found that those with BPD may experience the following ideas of reference. 1. Believing that strangers' laughter is about them. 2. Feeling that people talking quietly nearby are discussing them. 3. Feeling that a group's laughter or conversation is meant to mock or criticize them. 4. Thinking that people in public places are staring at or judging them. 5. Believing that certain gestures or looks from others are secret signals about them. 6. Feeling that changes in the environment, like a sudden silence, are because of their presence. More extreme examples of ideas of reference those with BPD may experience were identified by Niemann-Sverdrup and colleagues in 2021. These were thinking that television or radio hosts are sending them special messages, interpreting song lyrics on the radio as being about their own life, and believing that news headlines or stories are indirectly referring to them. Finally, Michael and Van Baal, 2021, found that those with BPD may sometimes assume ambiguous social media posts are directed at them. These examples, documented in clinical research, highlight how ideas of reference in BPD often center on interpreting neutral or ambiguous social cues as highly personal and significant, fueling emotional distress and interpersonal difficulties. Follow me to learn more about borderline personality disorder. 4 ways identity disturbance manifests in borderline personality disorder, or BPD. According to a study by Wilkinson-Ryan, there are 4 distinct ways in which identity disturbance can present itself in BPD. 1. Role absorption. This involves over-identification with a single role or cause, for example, defining oneself solely as a caregiver or victim. Role absorption may mimic stability but reflects over-reliance on external roles to compensate for internal emptiness. 2. Inconsistency. This involves observable contradictions in thoughts, feelings, and behaviors. For example, rapid shifts in career goals or values. 3. Lack of commitment. This refers to an inability to sustain long-term goals, relationships, or values. 4. Painful incoherence. This was the most distinguishing factor for BPD and refers to a uniquely distressing subjective experience of self-fragmentation and self-disjointedness. For example, I feel like a ghost masquerading as a human. All 4 factors significantly differentiated BPD patients from those with no personality disorder and those with other types of personality disorders, suggesting identity disturbance is a core feature of BPD. The data from the study also hinted at 2 BPD subtypes. The first possible subtype was the emotionally dysregulated and dysphoric subtype, which was linked to painful incoherence and inconsistency. The second was the histrionic subtype, which was associated with role absorption and lack of commitment. The McLean Study of Adult Development, or MSAD, found identity disturbance declines with recovery, but residual negative self-views may persist. Other research has tied identity disturbance to dysfunction in the brain's cortical midline structures, which govern self-referential processing. The good news is that therapy can help very significantly. Mentalization-based therapy, or MBT, addresses incoherence by improving self-reflection. Dialectical behavior therapy, or DBT, targets the emotional dysregulation that drives inconsistency. Finally, narrative therapy helps integrate fragmented self-narratives. Why is life expectancy for those with BPD nearly 20 years shorter than the general population, and how can the risk of early death be dramatically reduced? Falk and colleagues, 2012, found that people with personality disorders, including BPD, had significantly shorter life expectancies, 63.3 years for women, that's 18.7 years shorter than the general population, and 59.1 years for men, which is 17.7 years shorter. These findings were corroborated by Hayes and colleagues, 2015, who also noted higher mortality rates among younger patients. So, how do we explain these findings? Kier and colleagues, 2021, reported that 5.9% of BPD patients died by suicide, with the risk peaking in their 30s. However, sustained remission reduced relapse rates to 10% after 8+ years. Additionally, Bjorkenstam and colleagues, 2020, found childless women with BPD had a 3-fold higher suicide risk compared to those who gave birth after their BPD diagnosis. Many people with BPD have a substance abuse disorder, and Kuo and colleagues, 2021, highlighted that comorbid substance use disorders quadrupled mortality risk in BPD patients, with young women at the highest risk. Another key factor explaining increased risk of early death in those with BPD is physical health. Obesity due to comfort eating, smoking in response to stress, and medication side effects, like metabolic syndrome from antipsychotics, all contribute to early mortality. However, integrated care models that address both mental and physical health can mitigate this. Yet another factor explaining early death in those with BPD was identified by Nordentoft and colleagues, 2020, as being that of unnatural causes such as poisoning and accidents, which is likely to be related to reckless and impulsive behaviors. However, despite these grim realities, there are reasons for hope. First, BPD has high remission rates. Zanarini and colleagues found 85 to 91% of BPD patients achieve remission within 10 years, with emotional stability improving over time as brain changes in middle adulthood often naturally reduce emotional volatility. One study found affective instability declines by 40% in BPD patients over age 50. Second, we now know there are effective interventions for BPD. Linehan and colleagues found that dialectical behavior therapy reduces suicide attempts by 50% and hospitalizations by 70%. Furthermore, Bateman and Fonagy found that mentalization-based therapy improves relational stability and reduces self-harm. Thirdly, it's important to note protective factors. Bjorkenstam and colleagues, 2020, found childbearing post-diagnosis lowered mortality risk by 65%, likely due to social support and purpose. Additionally, Falk and colleagues, 2012, found employment and education were linked to better outcomes. Stable partnerships and social support also correlate with longer survival. Finally, early intervention is particularly important. Chainin and colleagues found that adolescents with BPD showed particularly fast symptom reduction with tailored therapy. Psychotic episodes in BPD are more prevalent than has been historically recognized, generating increased attention in mental health discussions. Studies suggest that 25% to 50% of individuals with BPD experience auditory verbal hallucinations, with similarities to those found in schizophrenia concerning frequency, duration, and distress, according to Lopez Sola and colleagues, 2019. These distressing auditory experiences often include negative, critical, or abusive voices, which may be linked to abusive figures from childhood. Those who experience them have higher rates of suicidality and hospitalization, according to Zanarini and colleagues, 2019. Furthermore, 15% to 30% report paranoid delusions, which are often transient and stress-related, but can persist over time, according to Stone and colleagues, 2018. Severe dissociative symptoms, such as derealization and depersonalization, affect nearly 50% of individuals with BPD and frequently intersect with psychotic experiences, according to Deloitte and colleagues, 2020. Neuroimaging studies have revealed that auditory verbal hallucinations in BPD engage similar neural pathways to those in schizophrenia, indicating amygdala hyperactivity and impaired cortical modulation, according to Spreng and Grady, 2010. Notably, these symptoms typically emerge during adolescence, highlighting the critical need for early detection to prevent chronic progression of the disorder.
Is your sleep delayed and fragmented, leaving you exhausted? This can be due to a disruption of circadian rhythms in borderline personality disorder. Late nights, unstable moods, and endless fatigue. Could a misaligned body clock be worsening BPD symptoms? If you have borderline personality disorder, you might notice your sleep feels off, staying up too late, struggling to wake up, or feeling exhausted no matter how much you rest. This is not just fatigue. Research shows BPD actually disrupts your body's natural rhythms. Here is what we know. Most BPD patients fall asleep 1 to 2 hours later than others and wake up later even when they try to adjust. This is similar to having jet lag, only it is chronic. They also have weakened daily rhythms, so for those with BPD, there is less distinction between daytime and nighttime energy levels. Bursts of energy tend to be random, so the person may oscillate between activity and passivity that is less related to the time of day. This makes it hard to maintain consistent routines. These sleep rhythm problems are linked to hormonal chaos. Melatonin, the sleep hormone, releases at wrong times, and patterns of cortisol, the stress hormone, become irregular. This worsens mood swings and emotional reactions. Poor sleep also aggravates many BPD symptoms, for instance, reduced impulse control, increased emotional volatility, increased paranoia, increased stress sensitivity, and increased levels of psychosis for those affected by it. What can help reset our internal biological clock? Morning light therapy, 10 to 30 minutes upon waking, is one approach. Strict sleep scheduling is another, whilst dialectical behavior therapy and sleep coaching combines emotional and rhythm regulation. BPD and psychosis, the overlooked connection. Research now suggests that psychosis in borderline personality disorder is a critical marker of severity, demanding clinical recognition. For decades, psychotic symptoms in borderline personality disorder, BPD, were dismissed as less severe than those in schizophrenia. Cutting-edge research now reveals these symptoms are not only real and distressing, but also a stark indicator of disease severity. Yet countless patients still face misdiagnosis, undertreatment, and invalidation. If you've been told your hallucinations or paranoia aren't serious because of your BPD diagnosis, the science unequivocally supports your experience. We now know that up to 50% of individuals with BPD experience hallucinations, commonly auditory, while 20 to 30% report delusions or paranoid ideation, often indistinguishable from those in schizophrenia in terms of distress and frequency. Despite DSM-5 framing these symptoms as stress-related, studies show they can persist for years, with auditory verbal hallucinations, AVH, often chronic and severe. Auditory verbal hallucinations in BPD share features with schizophrenia, including being perceived as coming from an external location, having malevolent content, for example, you are evil, and causing functional impairment, for example, obeying commands, suicidal triggers. So, psychotic symptoms in BPD are not imagined or less than. They are a documented part of BPD's neurobiological and cognitive spectrum. If your psychotic symptoms have been minimized, you're not alone. But this oversight can have life-threatening consequences. Indeed, BPD patients with psychosis have higher suicidality. 86% attempt suicide versus 28% without psychosis. Also, those with psychosis experience more frequent hospitalizations. Psychotic symptoms often correlate with childhood trauma and acute stress, underscoring their roots in real disruptions of the brain's biochemistry. Clinicians frequently misattribute psychosis in BPD to dissociation or dismiss it due to historical stigma, delaying appropriate care. Psychotic symptoms signal a need for tailored, compassionate intervention, not invalidation. The ICD-11 now includes psychotic symptoms in BPD criteria, which is promising, as it reflects the start of a shift toward dimensional, trauma-informed care. As awareness regarding BPD and psychosis expands, significant systemic biases result in symptoms being under-recognized. Clinicians face the challenge of balancing skepticism and validation, ensuring experiences are taken seriously to improve patient outcomes. Why happy memories can hurt. The paradox of nostalgia in borderline personality disorder. For individuals with borderline personality disorder, BPD, nostalgia can evoke warmth while also triggering intense emotional pain. Reflecting on joyful past experiences, such as happy relationships or carefree moments, should be comforting. However, it often leads to feelings of grief, despair, or self-sabotage. For instance, seeing a wedding photo may prompt thoughts like, "I was happy then, but now I'm alone," which can drive behaviors like self-harm or substance use to cope with the stark contrast. When recalling joyful events, individuals with BPD may initially feel elation but quickly descend into despair, becoming hyper-aware of their current struggles. This unattainable joy amplifies feelings of inadequacy and loss. Happy memories typically involve significant others who may no longer be present, intensifying feelings of loss and fear and transforming nostalgia into anxiety. Individuals with BPD often view experiences in extremes. Recalling a joyful moment might lead to initial catharsis, but can spiral into profound despair when faced with their current reality. This dynamic, known as the contrast effect, can heighten feelings of emptiness and loss, as happy memories evoke thoughts like, "I'll never feel that way again." Additionally, memory distortion plays a role, as individuals with BPD may reinterpret positive memories negatively over time. Research indicates they tend to contaminate past joys with later negative outcomes, such as thinking, "That vacation was perfect until I ruined it by fighting." Brain imaging explains why individuals with borderline personality disorder respond differently to comforting memories. A 2024 study found that, unlike healthy participants who experienced increased happiness from joyful recollections, those with BPD showed diminished emotional responses. They rated happy memories as less uplifting, with brain scans indicating weaker activation in reward processing areas like the medial prefrontal cortex and hippocampus. Consequently, individuals with BPD often feel more distress than joy when recalling positive memories. This suggests that happy memories are viewed through a lens of loss. Healing requires rewiring the brain to allow joy without accompanying pain. Research-backed strategies such as structured recall, cognitive reappraisal, and somatic techniques can aid in reconnecting emotions to past experiences without overwhelming distress. Can you relate to any of this? Please leave a comment. When the mind plays tricks. Cognitive symptoms in BPD. About half of people with borderline personality disorder experience temporary mind tricks. These have similarities to, but also differences from, psychotic symptoms in primary psychotic disorders like schizophrenia. Examples include feeling suspicious of others in the absence of sound, objective reasons, but knowing on some level it's exaggerated. Another example is hearing brief voices or seeing things but realizing they're not real. Thirdly, those with BPD are often prone to feeling disconnected from the body or surroundings. Often these symptoms are related to childhood trauma. You see, severe, protracted, repeated childhood interpersonal trauma can change the brain both functionally and structurally. Here's how. The brain's alarm system, amygdala, gets too sensitive, so small stresses feel like emergencies. Another part of the brain, the thinking center, prefrontal cortex, struggles to calm emotions, so dissociation becomes a coping mechanism. In other words, the brain shuts off, protect itself. These alterations to brain development caused by trauma can help explain the tricks our brains can play on us. For instance, paranoia may occur because the brain has learned to expect danger everywhere, and hearing voices, it has been theorized, may be the result of fragmented and not fully processed trauma memories surfacing strangely. Finally, in the case of feelings of dissociation, such as depersonalization and derealization, these may be explained as a response the brain has learned to escape unbearably painful emotions. These so-called brain tricks aren't signs of craziness. They're the brain's survival adaptations from early trauma and usually have key differences from full-blown psychosis. So what are these differences? Well, firstly, those with BPD who hear voices tend to be aware these voices originate from within their own head and not from an external source. Secondly, symptoms tend to be triggered by stress and are not constant. And thirdly, symptoms tend to be shorter lasting than in primary psychotic disorders like schizophrenia. Therapies like trauma-focused dialectical behavior therapy can help to retrain brain responses, and cultivating stable and emotionally supportive relationships can help the brain feel safe. Can you relate to any of this? Please leave a comment.